Good morning, everybody. I welcome everyone to the 15th Resident Orthopedic Clinical Classroom. This time with our Madras Medical College, Sri Balaji Medical College and Hospital Medical College Orthopedic Department is going to join with us. Professor Vijay Narasimha Reddy is going to join with us with their team. Our invited faculty is Professor R.H. Govardhan. He is a former director of Institute of Orthopedic Surgery, Madras Medical College, and he is a former secretary, former dean. He is the founder of Vasanti Orthopedic Hospital, and he is my beloved teacher. Thank you very much for accepting our invitation and come over here, sir. So I have to thank Professor Vijay Narasimhan from Sri Balaji Medical College and other unit professors, Dr. Madhukar, Dr. Pugalendi, and Professor Lionel John. I thank you for accepting our invitation and join us for this meeting. Our ROCC 15th program with the short cases. Medical College Orthopedic Department, we are going to present 2 short cases, and from Sri Balaji Medical College, they are going to present 1 long case. We will start with the short case first. Male. Rakesh Kumar, 16 years old male, studying 12th standard, studying in Villivagam, came to the OPD with complaints of giving away of a right knee for past 1 month. History of presenting this. Patient was apparently normal before 1 month, then developed a non-contact twisting type of injury over the right knee while playing cricket, followed by patient was not able to continue sports, but able to walk. Patient didn't seek any medical advice for 1 week, followed by patient had no change in pains and was initially taken to Periyar Nagar GH, where analgesics and physiotherapy was advised. Following physiotherapy, patient had a decrease in pain and swelling, but developed a giving away of a right knee, which was aggravated. Giving away of right knee, which was aggravated while twisting type, while turning and twisting, associated with a pain, which was sudden onset, gradually decreasing over the period of time, aggravated while squatting, and relieved by rest and medication. No history of any buckling, no history of clicks, no history of any stiffness, no history of any deformity.
Why he has come to the hospital?
Or giving away of right knee.
What he cannot do, then these are the very important things. What the patient cannot do.
Patient had difficulty while squatting, sir.
There is difficulty in squatting.
Squatting.
Okay. Any other things? Any of the students can come forward. What all other, see, this is a twisting type of an injury which has happened to this individual. And we must know exactly what the functions are disabled in this particular person, right? There are particular disabilities which may happen. So first thing you say that patient has got giving way. One, the patient has got giving way. What are the functions which will be affected in this individual? That you have to see. Ask him whether he can run. This is very important. A person who has been very active in sports activity is not able to run. Whether he can do stair climbing and climbing down the stairs comfortably.
Able, sir.
He
Able
is
to
able to
climb
do.
up, sir.
Whether there is any instability at that time.
No, sir.
No. These are the two important disabilities which one can find in a person who has got a twisting injury. What else you will ask? It cannot be a simple injury in the knee alone. There may be injury to the other internal organs. It can cause what it can cause. Patients can come with jammed knee. They can never flex. They can extend the knee. What is it called? Locked knee. A person can get locking of the knee if they have gotten associated problems of meniscal injury, right? In a sports injuries or as a innocuous injury like this, where the person is not able to run, but he can do other functions like walking, everything. We have to find out whether there is an associated meniscal injury which can cause locking. He is only 17 years, isn't it? Is there any sound created in the knee?
No, sir.
No sound. If there is a sound which is coming in the teenage, what will be your thought? What is the condition which can come into your mind? Anybody can answer. Windu nodular synovitis in a 17 years old boy.
Discoid meniscus, sir.
Discoid. That's the right answer. You can get a discoid meniscus. Usually it has got a soft thud sound which will come, and usually it is bilateral, not unilateral. It can come unilateral, but usually it is bilateral. Right, please proceed.
No history of any locking episodes. No other history of difficulty. No history of multiple joint pains. No history of fever. No history of loss of weight, loss of appetite. No history of fever and night sweats. No history of cough with expectorations.
This is not a long case. This is a short case. Now, patient's main complaint is only the giving way.
Yes, sir.
So we will proceed with the examination.
In a short case, it is always better to tell the important positive points and the important negative points and proceed with the examination. Time given to you is only 30 minutes.
General examination, sir. No other significant history, sir. Patient well built, well nourished. No evidence of any neurocutaneous markers. Evidence of ligamentous laxity present. Weight and score 9. Examination in supine arm span ratio. Arm span ratio more than 5 centimeter compared to compared to body height. Examination supine position attitude. Anterior superior leg spine at bilateral at same level. Hip in neutral. Knee in extension. Bilateral patella facing upward and outwards. Ankle at position of peace. Coming to inspection of right knee proper. L-shaped scab present over the tibial tuberosity, found to be healed by.
There is a scar there.
Yes, healed by secondary intention, no evidence of any sinus pus, no sinus scares, discharge, swelling present over the medial and lateral aspect. Head of the fibula over the lateral aspect would not be able to seen. And prone position, posterior aspect, not able, no evidence of any sinus swelling, dilated veins. Suprapatellar and parapatellar fossa present, able to be appreciated. Visible quadriceps wasting present.
So what you have seen in the parapatellar and suprapatellar fossa?
Hollowness, sir.
Is there any fullness of these fossae?
No
And
fullness.
you have to address this chap, find out whether there is wasting of the quadriceps muscle. ரெண்டு காலையும் காமிங்க. Can you appreciate?
Sir, quadriceps wasting present over the thigh region, sir.
Which muscle wastes faster?
Vastus
Out of the four,
vastus medius oblique, sir.
vastus medial is the right answer. Right.
Suprapatellar, parapatellar hollowness present. No quadriceps wasting present. Coming to palpation, inspector findings are confirmed. No warmth, no tenderness present over the medial joint line, lateral joint line, tibial tuberosity, medial and lateral tibial plateau, and medial and lateral epicondyle. No soft tissue tenderness present over the quadriceps patellar tendon and medial collateral ligament and lateral collateral ligament. No synovial thickening, no nerve thickening present over head of the fibula. Measurements, movements, reflection 0 to 130 degree.
1 minute. What are the palpatory findings at the level of the joint line which may denote problems to the underlying intra-articular structures? Can we make the knee bend? காலம் மடக்குவா. No, don't. 90 degrees enough. Just pull it a little bit forward. Yes. Now, are you able to feel the ligamentum patellae?
Yes, sir.
You have got a marking pen.
Yes, sir.
Mark the ligamentum patellae. It's very important when you are examining a patient who has got a problem of injury to the knee where we are suspecting some internal derangement of the knee. One should be very, very careful where exactly your tenderness is. No cursory examination saying that no joint line tenderness on the medial side is not going to be appreciated. That is the tibial tuberosity, and the ligamentum patellae will be still broader. It cannot be that narrow. You put your finger on the medial side of the ligamentum patellae. Okay. And then lateral side, right. And put a line along the upper part of the tibia. You can feel the tibia on lateral side as well as the medial side. Now you have got one on the medial side, you have got ligamentum patellae, the tibia, and if you palpate above, you can feel the condyle of the femur. That also you can. Condyle of the femur. That's the femur. That is the patella. Ligamentum patellae comes up to this. Okay. It comes up to this, right? And that is the femoral condyle. That's the femoral condyle. Now, ligamentum patellae comes up to this. Okay. And this is the tibia. Now, if you have got tenderness in this area, you have got a pathology in the anterior horn of the medial meniscus. Now, we can palpate the medial collateral ligament here, which is a resistant at the level of the joint line. And you can feel that. That is the anterior portion of the MCL. And as you go behind, the resistance will go away and you will feel a softness here. If you've got tenderness in the MCL region, then the pathology could be in the MCL or underlying mid portion of the medial meniscus. And if you go beyond that, then it is the posterior horn of the medial meniscus which is involved. Similarly, on the lateral side, you can palpate. So when you are dealing with any of the internal derangement, it must be very specific where exactly the tenderness comes. Okay. How will you make out a minimal fluid inside the joint? If you've got a very minimal effusion inside the joint,
Patellar fluid swipe test, sir.
now show it to us.
We have to check for medial, sir, and we have to swipe from the lateral side whether medial side is obliterating or not.
Now you
It is-
squeeze the suprapatellar pouch as well as the parapatellar side on the lateral side. If you find that there is a little bit of a swelling on the medial side, if you push on that side, the fluid will go away, right? That's how you will find out whether there is a minimal amount of effusion inside the joint. In these type of patients, they will have definitely an effusion. If that is possible, you have at least 50 to 70 ml of synovial fluid inside the joint. Okay. Now you are talking about the range of movements.
Range of movements. Flexion 0 to 130 degrees, sir. Extension 0 to 20 degrees, sir.
You mean to say there is hyperextension?
Hyperextension, sir.
Just demonstrate that.
So I will examine the left knee. Normal side.
Camera on the side one. You have to see the opposite side also.
First the normal side, sir.
Very good. So he has got a very lax joint.
No, abdominal side.
Very lax joint. So is it equal on both sides?
For hyperlaxity syndrome can be equal, sir.
No, that's what. Hyperextension on both sides is 20 degree. Okay. What else you want to show to us?
Coming to measurements, sir.
Yeah.
No limb length risk, sir. Quadriceps wasting of around 2 centimeter present, sir. No hamstring wasting, no calf muscle wasting present, sir. Coming to special test, sir. Special test for anterior ligament, anterior droid test positive, sir. Latchman test positive, sir.
To us.
First I will examine normal knees. Yeah, madam.
Before examination, tell the patient, I'm going to examine you. Before examining the patient, you have to tell the patient, I'm going to examine you. I'm going to sit on your foot. These are all the things you have to tell before examination, right? What you are looking for now?
Grade and any hard stuff or soft stuff. அதே மாதிரி தான் இங்கே பண்ண போறோம். சரி. The anti-drug is positive and found to be hard soft stuff, sir.
Demonstrate again. You seems to be pulling the entire body of the patient.
Sir, from the tibial tuberosity going to the joint length, sir, and posteriorly, fingers are relaxing the hamstrings, sir.
You see the picture there? No. Just see the picture alone. This position, what is more staring there? தம்பி இந்த லெஃப்ட் நீய மடிப்பா அதே அளவு மடி பார்ப்போம். வலது கால் மடிச்ச அளவே
இதுவும் அதே அளவு மாதிரி, அதே அளவு.
இடது கால் நல்லா காமிங்க. சைட்ல இருந்து காமிங்க. சைட். So is there any difference between the two knees?
Is there anything more prominent or less prominent? Just have a look and tell.
You said there is hyperextension both sides. Now, when there is hyperextension, you have to find out whether the tibial tuberosity is prominent, less prominent, whether comparable to the
Less
opposite
prominent.
side,
Tibial tuberosity less prominent.
less prominent, isn't it? What does it signify?
Can be less prominent in a PCL injury as well as
PCL injury, isn't it? So now you do it again, find out whether you have got anterior triad test positive or it is the lax PCL which is just coming forward. Please do. You can keep the thing a little bit down. You are trying to hold the thumb a little bit down, yes. And grab the calf region with your other four fingers. And now be an end point you are reaching, isn't it? Doesn't seem to be coming forwards. Like, what other test you want to show?
attachment test.
Yes. Why this anterior drawer test is not so reliable?
In case of medial meniscus tear, there will be a door stopping effect of
Correct.
negative anterior
Yes,
resistance.
yes. When there is a meniscal injury, a meniscal tear is there, it can prevent anterior shift of the tibia. Yes, right.
Thank you. I want to do modified attachment test. Bulk of the quadricep muscle.
Okay. Yes, it's very lax. Isn't it? Any other test you would like to do?
Posterior cruciate ligament. Posterior cruciate ligament, sir.
What would you like to do?
Posterior sac test.
Show to us.
Pen test. Normally not touching tibial tuberosity, sir. Not touching patella, sir. Godfrey test, sir. Sagging, sir.
Any other test?
Pivot shift test, sir. Posterolateral corner test. Okay.
Any other method of demonstrating this?
3. கொஞ்சம் okay.
Basically, what all the things that happens while you are testing the pivot shift? What exactly you do with the tibia at the level of the knee joint?
While valgus and internal rotation, tibia will be subluxated in extension.
You are exerting a valgus force of an internally rotated tibia. Find out whether it is subluxating from extended position to flexion. The reverse way also you can do. You can bend the knee to 90 degree, internal rotate the tibia, extend it to a valgus stress at that time. You will find the pivot shift positive, right? Okay. So what is your clinical impression in this patient?
Post-traumatic anterior cruciate ligament injury.
Yes, it could be an anterior cruciate ligament.
With generalized ligamentous laxity.
With generalized
ligamentous laxity.
People from Sri Balaji Medical College also can ask questions to the presenter.
Yes, Dr. Vijay Narthavan.
Sir, you can unmute your phone.
Dr. Marivar, can you hear us? Can you hear us, Dr. Marivar?
Sir, you are audible, sir.
I mean, can you comment about generalized ligamentous laxity diagnosis? Like you told the anterior cruciate ligament injury, that is fine. Can you comment about generalized ligamentous laxity in diagnosis? Can you hear me?
Yeah, you probably. Please repeat your question.
Sir, please repeat your question.
Actually, the diagnosis was post-traumatic anterior cruciate ligament injury. That's fine. He's also talking about generalized ligamentous laxity. And he talked about that in the diagnosis. Hello, can you hear me now, Manivaran?
Yes.
Yes, sir.
Yeah. See, actually, the question is like whether we can include generalized ligamentous laxity in the diagnosis, because that is only a, is that a finding can be included in diagnosis? ACL, post-traumatic ACL injury is fine. You want to include even generalized ligamentous laxity in the diagnosis?
Since we are dealing with a ligamentous injury, there is no harm in including, because the person has got so much of laxity and he has got hyperextension of the knee to 20 degree. So if a person is committing that there is a generalized laxity, he should be ready for substantiating your diagnosis with other findings of laxity in the other joints which you put through and show to the examiner. You don't want to include, is it?
McMurray's, he has not done the McMurray's test. McMurray's test is not done.
McMurray's test. Professor is asking me.
He's doing, sir.
Is it positive or negative? So that's all. Just for sake of completion, he's not mentioned about that. So whether it is positive or negative, that's what we want.
Sir is asking whether mechanized grinding test is positive.
Negative, sir. Negative.
Negative.
Another question is like he has only done for a unilateral, but he has not come for combined instabilities, tests for combined instabilities. Pivot shift he has done. So other for post-meter or post-lateral corner, those tests, dial test, all that he has not mentioned. So whether it is positive or not, I think it is customary to mention those tests in the examination. Or he cannot tell it is negative or it is positive. So that way I think he can tell that.
The test for post-lateral coronal done, dial test, reverse pivot shift test, external rotation recurrent test, all are negative, sir.
He is telling he has performed all the tests and it has been negative.
Okay, fine.
Thank you. Yes,
I
doctor.
think you can proceed further.
Yeah, thank you. What would you like to do?
We'll take X-ray, sir. Radiograph of
Yeah, show to us. X-ray finding of the individual.
By the time we are getting the X-ray, you just tell me, so you want to take up a X-ray. After that,
I'll take MRI, sir.
after that you wanted to do a MRI. So your prime diagnosis is, what's your prime diagnosis?
Post-traumatic anterior
Traumatic anterior cruciate ligament injury with generalized ligamentous laxity. Hope in the X-ray there is no bony injury. What other things you are going to look for in the X-ray?
for any technomonic signs for anterior ligament injury, for medial tibial plateau and lateral tibial plateau, borders of patella, head of fibula.
Suppose you are not able to find anything in the X-ray, what are you going to do next? Confirm your diagnosis. X-ray is ready. Read the X-ray.
X-ray of a skeletally mature patient, face is closer seen. Soft tissue shadows seem to be normal and alignment seems to be normal. No any deformity.
So what is your next step?
MRI of the right.
Do you have the MRI?
That femoral notch appears to be empty, sir. Empty notch sign is seen, sir.
Okay.
Next. Buckling of posterior cruciate ligament is seen, sir. And anterior cruciate ligament, there is a hyper intensity seen over the middle aspect, sir.
Yes.
The rumental diagonal appears to be opening upwards, sir. Next. This shows lateral side of tibia, sir. In that posterior meniscus is posterior horn of the lateral meniscus is seen to be injured. Three sections. So posterior horn of lateral meniscus might be injured.
Okay.
Can we see the AP view? Is it the tear of the lateral meniscus or it is the popliteus tendon which is seen there?
Sir,
The AP view, you are not able to see any extrusion of the meniscus on the lateral side.
yes, sir.
So, can we see further sagittal sections? No, not this one. Ah, that's the one. So, in this sagittal section, how many sections you have? Hey, that's enough. That's enough. That's enough. Can you go back? Yeah, with this, the leftmost picture, you are committing yourself whether there is a meniscal tear, isn't it? Right. In the frontal plane AP views, can you show us the posterior most portion? Yes. The right hand side, you can see that. And I am not very confident whether there is a posterior horn of the lateral meniscus, whether it is torn or not. I am not really confident. But the rest is fine. MCL is nicely maintained. LCL, yes, probably. Oh, that's also intact, very much intact. Okay, doctor. So what would you like to do to him?
So,
You said it is 16 years old boy, but do you think that you are surprised with the X-ray finding that it is fully matured skeleton?
maybe 16 years expected to 5 years closer, sir.
Maybe he is not 16, maybe more. தம்பி உன் வயசு என்ன படிக்கிற 12. So it must be 17 years or something. Not more than that. Yes. எங்கேயும் ஃபெயில் ஆகலையே எங்கேயும் ஃபெயில் ஆகலையே இல்லையா ரைட் 17. Okay, man.
Do we have the MRI report? No, you can tell me what are the findings in the MRI report.
Trace of effusion evident. Patchy bony bruise visualized over the posterolateral tibial plateau. Full substance tear of proximal and mid substance of anterior cruciate ligament with a femoral rupture. Complex tear with a vertical and horizontal components visualized across the posterior horn of lateral meniscus. Rest of the bones and joints appears normal.
Now you have confirmed you are having a case of anterior cruciate ligament injury with the lateral meniscus injury, but these things will be confirmed only at the time of arthroscopy. So all MRI is not the final. Arthroscopic finding is the final. What we are going to do?
Evaluate for generalized ligamentous laxity.
Then, as you told, what is the patient complaint?
Giving away.
Giving away. What you are going to do?
Diagnostic arthroscopy followed by anterior cruciate ligament reconstruction.
Diagnostic arthroscopy followed by anterior cruciate ligament reconstruction with or without meniscal repair or balance. Any questions from the Balaji Medical College, sir? As it's a short case, we are running out of time. We are going to complete and we start with the next short case.
We are okay with that. We are okay with this. Fine. Proceed.
Thank you so much, sir. Next case. Only half an hour for presentation as well as the discussion. We yet to have the long case from Sri Balaji Medical College.
Kapil.
Hello.
Can we start now?
Good afternoon, sir. Myself, Dr. Shanmugasundaram, final year postgraduate from Madras Medical College, presenting my short case, sir. Patient is a 20 years male, Mr. Saravanan, who is studying BA History, residing in Thandiarpet, came with chief complaints of pain in the right knee for the period of past 6 weeks, sir. History of presenting illness. Patient was apparently asymptomatic 6 weeks back. Then there is a alleged history of road traffic accident, skid and fall from two-wheeler, sustained a closed injury to the right knee. Immediately after the injury, patient developed pain not associated with swelling. Patient was immediately able to wait, bear and walk. Patient went to a nearby private practitioner where X-rays were taken, and he was diagnosed to have a lesion in the distal femur, for which he was referred to Rajiv Gandhi Government Hospital for further management, sir. Here after admission, patient underwent surgery in the right knee, which was 2 weeks back. Complaints of pain in the right knee, which was period of 6 weeks, sudden onset, non-progressive, continuous dull aching type of pain, non-radiating, no diurnal variation, no history of night pain or night cries, aggravated on squatting, sitting cross-legged, relieved on rest and medications. That's a history of difficulty in sitting cross-legged, history of difficulty in squatting, no history of difficulty in climbing upstairs or downstairs. There's no history of locking of knee or clicking sensation. There's no history of paresthesia or numbness. No history of fever, evening rise in temperature, or cough with expectoration. There's no history of loss of weight or loss of appetite. No other history is suggestive of any inflammatory pathologies, or no history of contact tuberculosis. Past history, history of fever at the age of 5 months, followed which patient's mother noticed deformity in both ankle, for which he was taken to nearby hospital and diagnosed to have polio, for which only physiotherapy was advised at the age of 5 months. Personal history, family history, and drug history, nothing significant. Family history, nothing significant. On examination, patient is well-built, well-nourished, no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy or pededema, no neurocutaneous markers, no generalized ligamentous laxity.
As I told earlier, you can cut short the negatives, important negative history, important negative points, then the important positive points. It is always better to cut short all those things for a short case.
Attitude of the patient. Patient examining the patient supine position, hip in neutral, knee in extension, patella facing upwards and outwards. Both ankle in the position of equinus. No visible limb length discrepancy. There is muscle wasting present in the right thigh compartment. There is equinus deformity of both ankles.
Muscle wasting only in the thigh compartment as well as the calf compartment.
Only thigh compartment. Inspection proper of the right knee joint. Inspection from the anterior aspect. There is a diffuse swelling in the anteromedial aspect of the distal thigh, extending 5 centimeters from the superior pole of patella, inferiorly up to the inferior pole of patella. Skin over the swelling is not stretched, not shiny, no discoloration. There's a linear surgical scar in the anteromedial aspect of the distal thigh, which was healed by primary intention. There is a fullness in the suprapatellar and parapatellar fossa. From the lateral aspect and posterior aspect, there is no scar, sinus, dilated veins, or visible pulsations or swelling. Palpation. All my inspectory findings are confirmed. There is localized warmth and tenderness present over the surgical scar area. There is a spherical swelling of size 9 cross 9 centimeter, extending 5 centimeter from the superior pole of patella, in the arising from the anteromedial aspect of the distal femur. Edges of the swelling is palpated. Surface smooth. Irregularity felt over the surgical scar area. Hard in consistency, not mobile. Skin over the swelling is pinchable, not tethered to the underlying bones. Palpation of medial and lateral joint line. Medial joint line appears to be distal compared to the lateral joint lines. Palpation of bony prominences, tibial tuberosity, borders of the patella, head of fibula, and lateral joint line, no tenderness. There is no swelling in the posterior aspects. No palpable mass in the posterior aspects. Movements. There's no fixed deformities in the right knee. Examining both active and passive range of motion. Flexion 0 to 90 degree. Terminal 10 degrees is associated with pain and muscle spasms.
What about the opposite side?
0 to 140 degrees is possible.
Demonstrate the range of movement.
First, active range of motion. கால் முட்டியை மடக்கிக்கும். It is from 0 to 90 degrees is possible. Out. Examining the passive range of motions. And it's restricting the further flexions.
What is your clinical finding, palpatory finding on the medial condyle of the femur?
There is a spherical swelling in the anteromedial aspect of the distal femur, sir, which is hard in consistency, not mobile. And surface is smooth, but there is a irregularity in the scar areas.
Anteroposterior irregularity or
only in the only underlying the scar tissue there is irregularity. Other areas it is smooth.
What about popliteal surface?
No palpable mass in the posterior aspects. Popliteal fossa.
Posteromedial condyle of the femur. Is there any swelling at that level?
No, sir.
Okay.
Measurements, there is no limb length discrepancy. There is muscle wasting of 4 centimeter in the right thigh compartments. Special test, varus valgus stress test negative. Examination of ankle, there is equinus deformity present in both ankles. Range of motion from 5 degree plantar flexion to 45 degree plantar flexion. I've also did a Silva scale test, sir. It is the equinus deformity is both is same in both knee flexion and extension, sir. And examination of spine and ipsilateral hip joint, it is normal. Neurological examination, power L2, L3, it is 2/5, sir. Only eliminating the gravity, patient is able to flex, sir. L4, L5, S1, it is normal on both sides, sir. Sensation is
L4, L5?
S1,
Normal.
Normal. 5/5, patient is not able to completely dorsiflex, sir, but power is against resistance, patient is able to do.
Just demonstrate.
ரெண்டு கால் மடிச்சுக்கோங்க. இந்த கணுக்கால் முட்டியை வந்து மேலே தூக்குங்க, இப்படி ரெண்டு பக்கமும் தூக்கணும். பேஷண்ட் சேஃப் 3/5 இஸ் பாசிபிள், சார். தூக்கிக்கோங்க அப்படி. இஸ் ரெசிஸ்டிங், சார். ஆங்கிள் டார்சிஃப்ளெக்ஷன் இஸ் ரெசிஸ்டிங்.
Tell me which is the dorsiflexion of the ankle.
Tibialis anterior.
So are you testing tibialis anterior or are you testing the dorsiflexor of the toes?
கால் மேலே தூக்கிக்கோங்க.
இந்த காலை நீட்டிருப்பா.
இது நீட்டிருக்கோங்க. வீட்டு விட்டுருங்க.
தெரிய மாட்டேங்குதா? Hang that down. Right, okay.
நல்ல மேலே தூக்கிக்கோங்க.
When he does that, what is happening actually? Just see that picture. It is cocking of the toes, isn't it? There is a drop of the first metatarsal. It's a clinical, classical sign of a tibialis anterior weakness. Did you see him walking?
Yes, sir.
What does it signify? What is the gait?
Patient has a high stepping gait, sir.
Then, with all these findings, still you think that tibialis anterior is normal. We should not get into trap. We should find out and we should exact them. You have to palpate the tibialis anterior whether it is working or not. The EHL and EDL can definitely will do the dorsiflexor. So we have to palpate the tibialis anterior tendon when the patient is doing the dorsiflexion to find out exactly whether there is nervous action. He has got a cavus deformity also. He has got cavus equinus deformity, right? Why he has got all these deformities? You are dealing with it, some tumor condition where your biopsy has been done. Why he has got all these? Did you ask him?
Post-polio residual paralysis.
You never told us whether he had a post-polio residual paralysis. You must include in your history itself that there was this patient suffers from post-polio residual paralysis and he has got weakness already, right? It is a concomitant finding. He is ambulant because of the various muscle grade. What we should never be in a position where the examiner can catch you. You must be on the upper hand. You should give all the information to them and then come to the conclusion, right? So you feel that this fellow, how old is he?
20 years, sir.
He's 20 years old chap who has got bony swelling on the medial condyle of the femur. Lateral condyle is normal,
Normal, sir.
without any breach anywhere.
No, sir. No,
No,
please.
there is no softness anywhere. It's a hard bone in a 20 years old. What is the duration?
After sustaining the injury, patient went to hospital, sir. It was totally for a duration of 6 weeks, sir.
Whether the person had any pain prior to that injury?
No, sir.
Was it an accidental finding?
Yes. Accidental findings.
Patient was asymptomatic throughout.
Yes.
So if a person is asymptomatic and he is only 20 years old, only one condyle is involved, and somebody has done a biopsy, what are the possibilities you will think in this judgment? Possibilities.
Tumor. Benign tumors.
Benign tumor, like
Giant cell tumors.
giant cell tumor is not a benign tumor. It
Locally
is
aggressive.
either benign. So you think in terms of a giant cell tumor in this patient. Do you think that the giant cell tumor will be asymptomatic for quite some time? This fellow has got no symptoms, isn't it?
No, sir.
It is an accidental finding, isn't it?
Yes.
Do you think that GCT can be an asymptomatic? The other side, the faculty is nodding their head no. What other possibilities you can think in terms of? Is it a metaphyseal swelling or epiphyseal swelling?
Epiphyseal swelling, sir.
Epiphyseal. Why do you say it is epiphyseal swelling?
The medial joint line is found distal compared to the lateral joint line, sir.
Medial joint line is disturbed. In what way? How a medial joint line disturbance can be a corroborative finding for your diagnosis? If the swelling is in and around the medial epicondyle, or it is very close to the joint line, then you can say it is an epiphyseal swelling. If it is above the level of the medial epicondyle, it could be an epiphyseal-metaphyseal junction. So where exactly your swelling is? It is an eccentric tumor, isn't it? It is an eccentric tumor in a 20 years old gentleman. So does it fit into your single diagnosis of a giant cell tumor? Or do you think in terms of other findings, the possibilities?
Chondroblastoma.
Chondroblastoma. Typically, it will come in only epiphysis. It will not come into the metaphysis. And what is the characteristic of chondroblastoma?
Site, it will be in epiphysis, age.
Epiphysis, age, and if it becomes progressive, it can cause very severe pain to the patient. Here it's a person who is asymptomatic, isn't it? Okay.
Any other benign conditions you can think of?
Which can produce thickening. Usually, a giant cell tumor will go on eroding the bone, and there will be classically it will be softening of the bone. Here you are telling that it is hard in consistency.
Aneurysmal bone cyst.
Aneurysmal bone cyst. What is against aneurysmal bone cyst?
Site.
Right, isn't it? Is more of a metaphyseal region than an epiphyseal region. If it is progressively increasing in size, yes, it can cause. Yes. Any other?
Think simple.
Simple bone cyst.
Okay, doctor. So we are thinking in all these possibilities, and already biopsy has been done. So let us see the X-ray. Okay.
It's an X-ray of a skeletally matured individual showing the anteroposterior and lateral view of right knee joint. X-ray shows the distal femur, proximal tibia, and proximal fibula. There is a expansile eccentric geographical lytic lesion in the medial condyle of the distal femur.
Just destroyed the medial portion of the femur, isn't it? So your palpatory finding is now in question. Whether there is any softening of the bone. Why don't you put your finger there? Bend the knee first. Bend the knee. Now we palpate on the medial side. That is the reason.
Is there any softening?
Some areas.
So now he has examined the medial aspect of a condyle, femoral condyle, and finding out that there is some areas, there is some softening of the bone.
So any other points of the X-ray you will tell? You only told about. You can describe the X-ray better, like whether there, what is the zone of transition? Can you hear me? They can't hear. Right. Hmm? சம்பளம் வருது. அவங்க பாஸ்
செகண்ட்
அது நம்ம
இல்ல சார் அவங்க தான் சார் வந்துட்டு அங்க எதுவும் ஃப்ரண்ட்ல
இதுதான் நினைக்கிறோம். இதுதான்
அது நம்மளுக்கு
ரைட் தெரியுது.
Sir, from MMC connecting now, just wait, sir. Just 2 seconds.
Not a benign condition. It is a malignant condition, right?
If it is a malignant condition, sudden increase in size, swelling within a short duration, 15 days, 3 weeks, sizable tumor will be there, sizable swelling will be there. It will be definitely associated with pain, stretching, all those things. You don't have a stretching here. No engorged veins you have seen, right? So
No, sir, just 2 minutes, sir. He has some technical issue in MMC that he'll be joining shortly within 2 minutes.
James are given whether it's particle breach or not, depending on the how much destruction, what destruction has been. This patient has regular graph. What is extended to the if you have used hormones like hydrogen peroxide, phenol, liquid nitrogen, or argon beads, will remove. They are all adjuvants. Adjuvants which are used as a chemical agent. What is extended to the tongue? We remove the capsule. Either large ingredient including down. What is extended to the tongue? Remove the pseudo capsules. We have to use a bone barrier. Remove all the right? That is extended to the tongue. We are going small pieces along with there, there will be additional type of imagination cancerous bone. They all has to be low. Then you do the outside. Giving kind of them, opposites can. Why do you want to extend to the touch? But more festival, sense. What is the normal advanced state? Change something that you are very normal touch. 30%. 30 to 50% of the we are physically teaching. We can use a bar. Some of the chemicals can be used to avoid attacks. The way you learn from the effect stability. You never need void there. You will be that. After the history. You can use cancer programs. You can use cement. Most of them then we use. You can also use cancer programs.
Incorporation is better.
It
It's more, it's biological.
nobody does tubular stud graft, man. Everybody does either cementation technique or packing with the cancerous graft. If the lesion is very close to the articular, subarticular region, then we pack with the cancerous graft and then put the cement.
sir, any question from the Balaji Medical College?
Let us find out why he has told
In addition to, actually, we couldn't hear the audio clearly. What was the management he had told? We couldn't hear it clearly, actually.
Sir, he was
Can you
telling
hear us?
after the biopsy information, if it is a giant cell tumor, he can go for a curettage. Then we were asking whether simple curettage or extended curettage, and why he has to go for extended curettage. And then he has confirmed he has to do a curettage as well as using chemical agents to avoid recurrence. This is what the discussion going on.
But he has opted for fibular stud graft.
So, okay. That is one thing. One more thing I just want to know, they only show the X-ray. Any other CT or MRI is there to analyze it better, or that is one. And two is like we saw the skin incision for biopsy was quite big. Okay, so this is there. So it shows a significant breach and all that.
Yes.
In the screen now we have shared the CT images, sir.
And we saw the knee joint. I mean, there was a big skin incision there. What was it for? Anything? Is it surgery? In surgery or what was done, sir?
It was a biopsy scars.
Okay, fine. So why was such a they could have tried some true-cut biopsies. It was not done somewhere else, or where it was done, sir?
Initially.
Is it open biopsy or it's a
Open biopsy, sir.
definite procedure?
No, sir. Open biopsy they have done, sir.
Open biopsy. Somewhere else, is it?
Here, sir,
Okay.
in Rajiv Gandhi.
In the government general hospital, they have done it, but the classical teaching will be, you must do a needle biopsy in these patients, or a true cut biopsy of this lesion first, so that your incision, while doing a definitive procedure, should not be troublesome for them. Now we can see that in this CT picture, your lesion is going in the subarticular region of the patellofemoral joint, right? So once you have cured it out, you have to pack that area with the help of a cancellous graft, support the subarticular region, then only you can pack either the cancellous graft or the cement. Now, why he is telling about fibular graft is because Dr. Singaravadi has published his results of fibular stud graft in these lesions, and with that publication has come. That is the reason why he is telling. Okay, you have got a valid evidence-based medicine in which a fibular. That's what I was repeatedly asking, but he is not coming out with the answer. I have read that article. That is why I am able to tell you. Okay. Shall we proceed with your case, Dr. Vijay Narasimhan?
We have a problem here with the visuals. The camera's connector is not there. So we have a problem with that. So we can either finish with this case. I think we can't project, we can't telecast there. The camera is not connecting.
Okay, sir. Okay, sir.
Okay.
So we will be talking elaborately with the tumor, benign tumor in a person like this in the distal femur. How will you confirm your diagnosis? You forget about this biopsies or everything. The patient has come with a swelling on the medial aspect. You have taken by X-ray, you have taken by MRI. MRI suggesting it could be a giant cell tumor. How will you proceed?
I'll confirm the biopsy.
What are the biopsies you know?
Incisional biopsy and excisional biopsy, core needle biopsy, sir. Core needle biopsy using a Jashadi needle, which is a 14 gauge needle. We have to extract more than 2 specimens. The surgeon who is going to perform the definitive procedure has to do the biopsy, and the principles involves a longitudinal skin incision to avoid transverse skin incision, and the
No, you are talking about a needle biopsy. Why the person is going to do the definitive procedure should do the biopsy? Or under his guidance, his assistants can do. Why the person who is doing the definitive procedure should perform biopsy?
The definitive skin incision should involve the present biopsy sites. Should be removed during the definitive procedure. The biopsy.
What is the problem in the biopsy scar or the needle passage?
Seedling of tumor cells.
Yes, doctor. Suppose if it is a malignant one, the seedlings from the tumor can come through the passage and the chances of recurrence from that area is very high. That is the reason there is a say the person who is going to do the definitive procedure should do the biopsy. Okay, one is the needle biopsy. What is the advantage? What is the disadvantage?
Minimally invasive, like a needle biopsy. Disadvantage is sample size will be less compared to the open incisional biopsy. It will be less in amounts.
Suppose in the needle biopsy, you are not able to get the adequate amount of sample. The pathologists are not able to come to a conclusion with the needle biopsy. What is the next procedure? Open biopsy. Then now you talk about the scar. How the scar should be?
Incision should be a longitudinal incision. We should go through a single compartment. We should not pass more than one compartment. Sample should be acquired from the active cells. Even in case of malignant tumors, we can take it from soft tissues also. In case of a sample from bone, it should be the bone window should not be square, should be oblong. It will be a less.
Why it should be a oblong window rather than a square window?
Square will be stress rises, with chances of fracture.
The chances of pathological failure, pathological fracture is more with a square one. There is a reason people wanted to take a oblong one or a oval one to take up all the things, right? Suppose if there is a bleeding, what will you do when you are doing a biopsy? My question is, can we place a drain or not?
Maximum we should try to avoid drains. Even if it is required, it should be along the line of skin incision.
That is very important because at the time of doing the definitive procedure, the scar as well as the drain passage has to be taken to avoid recurrence. Suppose if it is an inaccessible area, what kind of biopsy you will prefer? CT guided biopsy. Again, what is the disadvantage of the CT guided biopsy and what is the advantage of the CT guided biopsy?
Advantage is minimally invasive. Disadvantage, adequate sample is difficult to obtain from CT guided biopsy.
Okay, then after the confirmation, if it is a GCT, what are the investigation you would like to do and why?
Renal function test should be done, sir. We'll be using drugs post-operatively, so zoledronic acid. So preoperative renal function test should be done, sir. If we are planning for cementation, in that case also renal function test is important, sir.
Any giant cell tumor is only a benign or it is somewhat different from benign?
It's a locally aggressive tumor, so
it's a locally aggressive tumor. Probably for this patient, it would be a benign. If it is aggressive, where it will go?
to rule out metastasis, we have to take CT chest and look for lung metastasis.
That's what I wanted you to tell. So that is 3 to 5% of the tumors can metastasize to the lung. So always you keep a suspicion that the giant cell tumor would have been an aggressive one. So if you say aggressive one, it is better to take up a CT chest also.
This tumor seems to be quite a big one. Unless otherwise we saw the CT as well as the MR picture, right? After the curettage, these patients might develop a dissociated type of a pathological fracture of the condyle alone, which will be a difficult one to treat in this particular individual. You have to be very careful that you should produce certain amount of bone formation in the local site. You should do a extended curettage. You can support the area with a stud graft, but I would prefer to have subchondral cancerous bone graft supported with the cancerous bone graft as well as the stud graft, right?
Sir, are we audible to Balaji Medical College?
we are able to see you. Why it is not possible to?
Hello,
Dr.
Manimaran.
Yes, sir, tell me, sir.
Sorry, sir, we're not able to continue our presentation because of some technical glitch. The camera is not connecting. So,
You are now audible, sir. You want to ask some questions to the presenter?
no, sir.
So as we are not able to get the connection between our center as well as the Sri Balaji Medical College, we are going to close with the discussion now. Thank you very much for participating in this ROCC. And I have to thank Dr. Vijay Narasimha Reddy and other professors in Sri Balaji Medical College for having contacted us for this classroom. Next time, with a good connection, we will be having the next case for discussion. And I would like to thank our professor, our former professor, Govardhan sir. Thank you so much, sir, for having come here.
Thank you, sir. Thank you very much.
Thank you so much, sir.